USA. If she is available on the webinar, she'll also join the panel discussion.
So our task has been made, I should say, easy or maybe difficult by Dr. Bela Bhatt. I presume everyone present here is an obstetrician. Is that so? How many of you offer first trimester screening or NT scan or a dual marker as a routine to your patients? Okay. And to high-risk patients? Exactly. Exactly. Thank you so much. So that makes my job a little easier. Yes, fetal medicine as such is a subspecialty of obstetrics only. Just as ma'am said, I am an obstetrician by birth, but a fetal medicine specialist by fate. So this brings us to this topic, 11 to 13 week 6 days scan, where we stand today. Is it actually a myth, or we are showing stars that is not possible, but it is just a marketing gimmick? Well, let's see how we conclude with our esteemed panelists. I'll just give a brief introduction to the topic that has already been given to a large extent. In the 1980s, amniocentesis was the only procedure available for genetic testing, and as a policy it was offered to every pregnant woman above the age of 35 years. But as Dr. Bela Bhatt said, at that point in time and even till now, most of our reproductive population is constituted by much younger women, and hence most of the aneuploidies, almost 90% of them, are missed if we were to offer the invasive testing only to the pregnant women above the age of 35 years. Hence, the need for a screening test for this population was felt. Gradually, this resulted in evolving the concept of nuchal translucency and the first trimester screening. So why a first trimester scan? We've already been doing our anomaly scans at 18 to 20 weeks. The reason has been we have better equipment available. We can see much more than what we could at earlier times. Now we understand the human embryology in a much better manner, and in an unfortunate event of a defect, it avoids the late terminations, and at the same time, in high-risk pregnancies, it is highly reassuring for the woman to know that yes, her baby is going to be fine. So with time, the ultrasound has evolved into two kinds of tools: as a screening tool for chromosomal defects and preeclampsia, and as a diagnostic tool for dating if it has not already been done, to establish the chorionicity and amnionicity in multifetal pregnancies, and also for anatomic evaluation of the fetus. So this brings to my first question. Dr. Bharti, how did you use the screening modalities to get the optimum results?
As in the previous lecture, Dr. Bela has already explained that how in the first trimester, we are first, though it is a universal screening, still maternal age holds importance. And when we only use maternal age as a screening test, then the chances of detection is 30%. And we all know that each and every female, pregnant female, can have a Down syndrome baby. So, we follow a sequential methodology. We take this thing as a background risk, also called as a priori risk. And all the different screening methods, including the biochemical markers, as well as the ultrasonological markers that we measure in first trimester, like the biochemical markers like PAPE and beta-HCG combined, along with the nuchal translucency. When we take them individually, they act as likelihood ratio. And by adding each and every ratio, a single ratio to the a priori risk, we have a new risk with us. And the moment we keep on adding a new screening test, our detection rate increases. So the first thing is to follow a sequential stepwise methodology. And as ma'am had already told you, that new things have come up, like the detection of nasal bone in trisomy 21 detection, and the ductus venosus measurement, as well as the tricuspid regurgitation. They further help us to improve our detection rate and thereby optimizing the result. Another thing which is very important is the ability of the ultrasonologist or the operator. So this holds the key, because to measure the nuchal translucency in the right way, as well as the measurement of ductus venosus and looking for the nasal bone, this is very important. Thank you.
Alright. The audience is always welcome. You can raise your hand and ask a question at any moment you feel like. So this is the
I just
slide
like
for
to
Sure.
add one thing, that optimum screening for any patient would depend on what weeks of gestation patient presents to us.
Exactly.
Suppose the patient presents to us in first trimester, for screening purpose definitely would be combined test, that is nuchal scan and
This is
nasal.
what we are discussing today. It is
And
only
if the
11 to
patient
30
comes
weeks.
in the second trimester,
Definitely.
naturally it would be quad test and genetic sonography.
Definitely. So this is basically a chart to represent how the risk for the trisomies increases with the maternal age. This is the background risk, and we keep adding the markers to improve our, forget the final patient specific risk. To the next question, Dr. Shilpin has just come from the OT and straight away bombarded with the question, why should there be a limit of 11 weeks or 13 weeks? Why not earlier or why not later?
Let me take some breath.
Sure. In the middle.
Okay.
For all screening purposes, we basically take the CRL as 45 millimeters to 84 millimeters. 11 to 13 weeks is basically just a representative figure. It is basically the CRL that is taken into consideration.
See, before 14 weeks, if we want to if we require termination, then it would be first trimester termination. That would be easier. And earlier than 11 weeks, if some invasive procedure is required, then it would not be possible. If we require CVS or chorion villus sampling, then before 11 weeks it is riskier, means it increases the risk of limb reduction defects like that. So that's the main reason we have kept it 11 to 14 weeks.
So is that clear with everyone?
Plus some of the anomalies may not be
Yeah.
picked up before
Yeah.
11 weeks, so it is better to keep it below.
Megacystis, physiological herniation of the bowel, all this acrania, all these defects can be detected only after if the gestational age is more than 11 weeks.
And beyond 14 weeks, it's technically also difficult to
Yes.
measure nuchal scan, because the fetus becomes vertical and the nuchal thickness even in chromosomally abnormal fetus reduces after 14
Yeah.
weeks. So.
Even in chromosomally abnormal babies, the antiment absolutely resolves.
Even the bladder, the detection of bladder is complete by 12 weeks.
So the next question, what is nuchal translucency and how to measure it? Dr. Bela.
Basically it is ultrasonic translucency that we see behind the neck of fetus because of fluid collection, and there are specific criteria how to measure it. Number one, the zooming should be such that only the head and upper thorax occupies the entire screen. It has to be a mid-sagittal section in which we see the tip of nose, a square palate and a translucent diencephalon at the center and nuchal membrane at the back. The zooming has to be such that with every movement of our cursor we see only 0.1 millimeter movement, increase in the measurement, and the cursor should be kept in such a way so that the horizontal bar fuses with the inner lining of that defining space, so that we get the exact measurement. The highest measurement has to be taken 2, 3, 4 times, and the highest measurement with all criteria fulfilled should be taken into account. And we have to see to it that we are not looking at the amniotic membrane, which can be seen with the fetal movement going away from the nuchal membrane.
So the nasal tip, the nasal bone, the square shaped palate, the diencephalon and the nuchal membrane. I hope the things are clear and I am not confusing you any further.
Pardon ma'am, what is the prognostic value of only increased nuchal translucency?
We'll come to that. So this is from the FMF website, that the nuchal translucency gradually increases with gestational age, and a 2 millimeter crown rump length is the 95th percentile at 45 millimeter of gestational age, which comes to about 3.2 millimeters at 85 millimeters of gestational age. So 3.2 millimeters may be abnormal at 11 weeks, but 3.2 millimeters is absolutely normal at 85 millimeter of gestational age. So this brings us to our next question. How would we manage the fetuses with increased nuchal translucency? Dr. Shilpin.
We should go for CVS to rule out any chromosomal anomalies. But if at all report of karyotyping comes back to normal, we should advise the patient regarding target scan at 20 weeks, and also we should rule out any cardiac anomaly at 20 to 22 weeks of gestational age. And if there is increased nuchal translucency, apart from chromosomal anomalies, there are chances that their fetus may be having many other anatomical abnormalities.
Just to add, so does that mean increased nuchal translucency means we should abort the patient, abort the baby? No.
First of all, if only nuchal translucency has been taken into account, we have to look for other 3 soft markers, that is nasal bone, ductus venosus and tricuspid flow, and then we'll take the decision. 18-20 weeks.
So the chemical markers
And double marker is
chemical markers.
Everything. That is first step. So the clinical implications, we will review the patient at 14 to 16 weeks to check if the nuchal translucency thickness increase has resolved or not, or if it has at all evolved into a nuchal edema or a cystic hygroma. If it persists at 14 to 16 weeks, there is a possibility that there might be congenital infections or other genetic syndromes which are beyond trisomies and a karyotype. And if it persists at 20 weeks also, then we do need to tell them that there is a 10% risk of evolution to hydrops and perinatal death or a live birth with a genetic syndrome like Noonan's. But at the same time, the point that I wish to convey from this podium is an increased nuchal translucency or an increased risk in first trimester does not mean that we abort. So many of the babies, even if the nuchal translucency is something like 5 millimeters or 5.5 millimeters, may be absolutely normal as well. So we need to get our risks calculated and give the exact figure to the womb. So this brings me to the next question. What are the other markers for chromosomal defects at this gestational age? I mean to say maternal age we've already taken into account, gestational age we've already taken into account, and nuchal translucency also we've already taken into account. Dr. Bharti.
Now, as we have already discussed earlier, the other markers that we include just after the nuchal translucency is the measurement of ductus venosus, then looking for the nasal bone. If a nasal bone is absent or hypoplastic, then there is 60 to 70% chance of the baby being trisomy 21 and 55% chance of being trisomy 18. Now then we add to the tricuspid regurgitation. Any presence of tricuspid regurgitation again is a marker for trisomies. Then there are other markers in the form of structural defect that are present, and they point towards different trisomies, like the presence of short maxilla, which is an indicator of trisomy 21. Then we can see when we measure CRL, if it is less, it is sometimes a marker of, it points towards growth restriction, which is again seen in trisomy 18 and 13. Then the presence of omphalocele is exemphalos, that is also seen with trisomy 18. Then trisomy 18 also shows presence of bradycardia, and then in trisomy 13 we sometimes see holoprosencephaly, we see tachycardia, and it also the presence of exemphalos in these cases. So they are sometimes added markers that we should look for in such cases.
Perfect. So, but at the same time, although I have like tabulated them, but these can be overlapping. Megacystis can be there in trisomy 18, and similarly a single umbilical artery can be there in trisomy 13. So unless we have our karyotype report or a FISH report, we cannot be sure, we can't label that this is trisomy 18 or this is trisomy 21 or trisomy 13. So just as we keep adding our markers, Dr. Bela has already elucidated in a very fine manner that the detection rate of trisomy 21, as we take it as a benchmark, is best when we combine the maternal age, the nuchal translucency, the nasal bone and the dual markers at 11 to 14 weeks. We won't be going into the biochemistry because it has already been taken up. So this is the next question. We don't have Dr. Asha Rich Singhani with us. So I'll pose this to Dr. Bela. Can we predict preeclampsia, and what is the sensitivity and specificity of this screening at this gestational age?
Well, we have to start right from the history, the demographic factors, the BMI, past history of preeclampsia, history of eclampsia, the PIH in mother, history of smoking, and all these demographic factors, along with mean arterial pressure and PEPE. These are the three things which will help us predict preeclampsia at 11 to 13 weeks nuchal scan. And the sensitivity of this, when all these factors are included, it is around 88% with the 10% false positive rate. So we can predict it, especially the early PIH it is more sensitive for early PIH rather than late PIH.
Basically, what worries us is the early PIH. Late PIH is still better manageable. There are biochemical markers also, a PAPE as well as placental growth factor. But as of now, I don't think they are, at least placental growth factor is not being routinely offered. So we should stick to the mean arterial pressure, the history and the uterine artery PI. Especially coming to uterine artery PI, a normal uterine artery PI at 11 to 13 weeks has a high negative predictive value. Meaning by that, if the uterine artery PI is normal or within the normal range at 11 to 13 weeks, we can be relatively comfortable that this patient most probably would not develop PIH or IUGR. So again to Dr. Bela, how can we diagnose chorionicity and amnionicity in multifetal pregnancy?
The first and most important thing is it can be diagnosed, chorionicity can be diagnosed as early as 10 weeks of pregnancy. So in first trimester itself we can diagnose, and there is a lambda sign and T sign for the same. Lambda sign is placental, triangular placental extension which can be seen at the junction of membranes and placenta, and that is diagnostic sign of dichorionic pregnancy, which is definitely seen right from 10 to 14 weeks of pregnancy. May not be able to seen after that, but that doesn't negate dichorionic pregnancy after that. But 10 to 14 weeks is the right time you should diagnose the chorionicity. And in case of monochorionic pregnancy, this is not present, so that you get inverted T sign at the junction of membranes and placenta. So this is how you diagnose chorionicity in first trimester. So any report of twins has to go with chorionicity. You can't just write a twin live intrauterine gestation. You have to mention whether it is dichorionic or monochorionic, because the prognostication of both is very, very different. You have to counsel the patient that these are likely complications because it is monochorionic, whereas it is better if it is dichorionic.
I hope it is clear to everyone. So the next question, why are we so much worried about monochorionic pregnancies? Because of all the complications like TTTS, that is twin-to-twin transfusion syndrome. Dr. Bharti, in monochorionic twins, can we predict twin-to-twin transfusion at 11 to 13 week scan?
Yes and no. It is seen, it is seen that in monochorionic twins, the presence of twin-to-twin transfusion, only if it is severe in the early stage, then only there are certain markers that are also they are just in studies. So there are very small samples that have been taken, but I will just mention one is that when we are measuring the ND, if there is a discrepancy between the nuchal translucency of both the fetuses, then this sometimes predicts towards that the baby will develop twin-to-twin, the babies will develop twin-to-twin transfusion, and the chances of prediction is that it can predict around 30%. Then the other finding that is still undergoing studies is the ductus venosus. Now, ductus venosus, when we measure both the ductus venosus, the baby, which is the affected baby, that is the hypovolumic baby of both the amongst the monochorionic twin, sometimes shows reverse or absent diastolic, absent flow.
That this would be a sign of failure only, actually.
Yeah, again. So this is another predictor, because what is happening in TTTS is that one baby is hypervolumic and other is hypervolumic.
Yeah.
So this is again another predictor.
Whenever we are measuring the NT, if there is a discordance in NT measurement of one fetus and the other fetus by more than 20%, almost 30% of these babies would develop TTTS. On the contrary, a lesser discordance would almost ensure a normal monochorionic pregnancy. The risk of TTTS is less than 10% if the NTs of both the fetuses are almost matching. So the most important, actually, aneuploidies was the primary reason that the first trimester screening was introduced, but I can assure you that even anatomical defect detection is really highly sensitive at this gestation. So Dr. Shilpin, how realistic is anatomic defect detection at this gestational age?
Yes, it's true. We detect almost more than 90% of the anatomical defects in 11 to 14 week scan.
These are just a normal anatomy are given. That this is all 11 to 13 week scan pictures that are given here.
Even major cardiac anomalies also you can detect. You can confirm at 18 to 20 weeks, but at least you can predict very well major cardiac anomalies. So nowadays we go for
It's saying hi.
11 to 14
The hand
weeks.
saying hi, everyone.
11 to 14 weeks scan for anatomical abnormalities.
So would you like to elaborate the categories of defects at this gestation? There are some anomalies which are always detectable at 11 to 13 weeks. Some can be potentially detected and some are undetectable. I've just given a brief list of what can be seen and what can be detected. Acrania, omphaloceal, a megacystus, holoprosencephaly. Just as Dr. Shilpin was saying, cardiac defect, this is a left hypoplastic heart. You can see this, the left side is, this part is relatively smaller when compared to the right part of the heart. A TOF and an AVST. So if we have, with your permission, 5 minutes to... Alright, so we'll just skip this. Just one case I'll just... Though this is a second trimester case, but just an interesting thing. Anything wrong with that head or brain? Anyone?
Can we answer?
Panelists will get it at the last. Anybody from the audience? Sure, it gets passed to the panelists, experts.
It's strawberry head.
Yes, this is classic strawberry head. And what were the other findings in this fetus? A subaortic ventricular septal defect, single umbilical artery, and clenched fist with pointing index finger. This was a trisomy 18 confirmed on amniocentesis. So this is what Dr. Bela was talking about, is the value of genetic sonogram. This fetus was picked up on ultrasound having trisomy 18, a low risk 23 years primey who had come at 21 weeks for her anomaly, unfortunately. Thank you so much.
Thank you, Dr. Shreshtha, for moderating the session so well. I would like to thank all the panelists and certificate of participation to Dr. Gayatri Singh, a very senior gynecologist of Moradabad.
So we've got permission to go ahead with the quiz questions.
And Dr. Rajan Rastogi from TMU. Dr. Gayatri Singh and Dr. Rehana Najam, please jointly give the memento to host. Any questions from the audiences?
Keep my well-earned memento on the side. Any clues about this? Anybody? Except the panelists, of course. Yes, this is bilateral CTEV. Whenever you see the leg and the foot in the same section, this is CTEV. This is again a marker. This was supposed to be a video, if this runs. Yes. Anybody? Yes, there are two things actually. This is twins with one twin having a sacrococcygeal teratoma. Should I run it again for? Okay. This thing, you can see it at the end. The small tumorous thing, this is the sacrococcygeal tumor, and the other baby is having a nice time seeing its sibling in trouble. Actually, anyone who's doing ultrasounds? Anybody? These are lying down adrenals and there are no renal arteries. So this is bilateral renal agenesis.
What was the PRS in that?
That I won't show, that is my secret. Huh?
You can make it renal agenesis by increasing the PRS.
Well, that is artistry. So this is again around 13 weeks only. I already covered it earlier. Yes, this is hypoplastic left heart which was detected at around 13 weeks. You can see that the left side of the heart is smaller as compared to the right side. The LV is much smaller than the RV. Very easy. Perfect. So this is the point that I actually, sorry? Yeah, double bubble sign suggestive of duodenal atresia. The point I wanted to stress was this is a marker of Downs. So all these babies need to be tested for Downs. Second thing, by the time we see double bubble, the baby is usually about 24 weeks. So this is a late sign. Any clues about? One of the commonest anomalies, the incidence is almost 1 in 250 at 12 or 13 weeks. Highly lethal. This is cystic hygroma. You can see the sacs, the two sacs bulging on the either side of the neck. This is cystic hygroma. This is a little, yeah, this is the spine. I'll just, this is the head, the neck, and the spine. Because of the abnormal posture, and these are the two dilated jugular sacs on the sides. Very common. Again, highly lethal, and almost 75% of these are associated with aneuploidies. That's all. Thank you so much. Special thanks to TMU and Dr. Archana Tandon for giving us this opportunity. Thanks. So, okay, so brings back to the favorite head. See, this, this would usually go past as a normal. But if you see, this is more of a rounded kind of a head. When we take the cephalic index, the cephalic index was something like 87.7, which is normal. Up till 86 is the cutoff. And the shape itself, see, ultrasound is basically about pattern recognition. The more you get accustomed to a normal, how a normal head look, this is what struck me. There's something wrong. There's something wrong. Immediately at that point in time, I was not smart enough to say that yes, this is strawberry head. But once I have the diagnosis, I have the confidence to stand in front of you and say that yes, this is strawberry head. They don't come labeled. Yes, yeah, hi there, I'm a strawberry head. No, no, it doesn't come like that. It is just that you come to feel that there's something normal, something not normal about this, and then you start looking. And when you start looking, you find other markers. The detection increases. Any questions from anyone about first semester screening? Either everyone is too confused or everyone is too clear. Eh? I think Dr. Parul is on his way.
Thank you, Dr. Shreshtha. You all can have a tea break till then. We are waiting for Dr. Parul and we'll be starting the panel discussion on PPH very soon.